Good morning, everyone. I'm Ivan Velikovic, and we will be talking about the intrathecal morphine and its implementation in Eastern European hospitals. I work in New York City for something that's called the New York City Health and Hospitals, which is actually the largest municipal healthcare system in United States. I work for a physician-affiliated group of the New York, and the hospital where I work is right here in the heart of the Brooklyn. It's called the Kings County Hospital, and it's in Brooklyn, one of the 5 boroughs of the New York City, where we work. We are very proud that we take care about 1.1 million patients with 43,000 healthcare professionals, and there are actually more than 200 languages that are spoken in the hospitals in New York City, and we are available to talk with the patients in more than 200 languages. So when it comes to the languages, I think that I should say Доброго ранку, дорогі друзі. And now we can actually go and start a discussion about the morphine. In English language, there is an expression to get the biggest bang for your buck. And our lecture is basically, or refers to this expression in the English language. So if you could ask me, when it comes to the anesthesia and particularly post-operative pain management, what is the intervention that will benefit the most of the patient, but on the same time cost relatively little and takes a relatively little effort to be introduced, and the intervention that vast majority of the anesthesiologists that work in Ukraine can do for their patients, I would say that would be the introduction of spinal and epidural morphine, particularly spinal morphine, for a wide variety of the procedures. So let's start with a little bit about the history of the use of the spinal morphine. So the first studies in United States were obviously on the animals, and studies start appearing in 1976, 1977, 1978, and this study here is actually a study on the pregnant rats and pregnant rabbits, where the spinal morphine was given to rabbits and rats, and when the pain was measured in these animals, the conclusion was that this spinal morphine caused a significant abolishment of pain that they were experiencing during the experiments. And this study was actually, it was published in Anesthesiology in 1979, and it was actually so important that since it was done on pregnant animals, it actually prompted editorial by a physician who was the chief of the OB anesthesia at Harvard at that time, by Milton Alper, and he actually gave the idea that could the spinal morphine be a new way to achieve the labor analgesia. And very soon, this was in 1971, the American physicians started giving spinal morphine to the patients, to the humans. So this is the study that came about at the same time, and it was actually done in men. They suffered from all different conditions, and with the doses of morphine that went from spinal doses that went from 0.1 to 1 milligram, all of them achieved significant decrease in the amount of pain that they were having. And once the scientists or the physicians figure out that spinal morphine works and abolishes pain in a man, very soon the application of morphine in a spinal space started in a pregnant women. So this is a study from American University in Beirut from 1981 by the Anis Baraka, and they give the spinal morphine to pregnant patients, to parturients, and with the doses of 1 and 2 milligrams of morphine, they all achieved significant comfort. If anyone of you has been giving spinal morphine, which I was told that there are people in Ukraine who use this, the spinal and epidural morphine. If you're currently doing the spinals for your patients and administering the spinal morphine, and you see the doses that were given here, which are 1 or 2 milligrams, you might think that something doesn't add up, that something is wrong. And yes, what is interesting that the first studies were done in humans. The doses that were used were basically used in the way that someone calculate how many times the rat is smaller than the human, and then multiply the weight of the differences between the weight of the human and the rat. So basically humans were getting the proportional doses that rats were receiving. Of course, that we know nowadays that these doses are almost 10 times higher than what we give nowadays, and based on these studies we can see that in some groups they have a 100% incidence of an itching and of nausea and vomiting. Obviously, with the doses that we give nowadays, this unwanted effect happened in way less percentage. One of my teachers actually worked in this time, and when they start using spinal doses in these first doses that were recommended, she told me that the patients were going to their rooms with the naloxone or a Narcan on their bedside to be used if they get a respiratory depression. So after a few years of using the very big doses of spinal morphine, things have changed. So by 1984, 1986, these are the two studies that they basically brought us the modern doses of the spinal morphine. These are studies by the Aboud and the Abouleish, and they are the ones that start using 0.25 milligrams or 0.2 milligrams of morphine for the cesarean sections, and they still got, with these way smaller doses than what was used at the beginning, appropriate effects. They achieved significant abolishment in the patient pain. with acceptable percentage of unwanted effects like itching, nausea, and vomiting. If we just looked at the literature over the years, we can see that spinal morphine has been used not only in obstetric anesthesia. It's basically every single abdominal surgery that you can think of. People have reported that they would first give a spinal to the patient with or without bupivacaine, but definitely added the spinal morphine, and then they would put the patient to sleep, and that patient will go through the cholecystectomy, through the exploratory laparotomy, through all different abdominal or orthopedic surgery, through the hernia surgery, through the different gynecological surgeries. These are the studies from all around the world where the successful use of morphine chloride has been described. Since I am both Serbian and American, I'm going to show you a few studies that were published by the authors who work at Vojno-Medicinska Akademija in Belgrade, and they also use it in the way for all different types of abdominal surgeries mainly. In United States, we like to describe that as a poor, another English expression, a poor man epidural, thoracic epidural, which basically means that in those hospitals where they work, and these were the studies from about maybe 10 to 15 years ago, the conditions were not right for the physician to use the thoracic epidurals for the big abdominal surgeries, and they would do the same as the colleagues that in the studies that I have just shown on a previous slide. So before the surgery, they would sit up a patient and do the spinal anesthesia with the different doses of bupivacaine, but they would definitely give a morphine, spinal morphine. And after that, they would just go and put patient to sleep. And post-operative results were way better than if the spinal morphine was not used. Patients were way more comfortable with tolerable side effects. When it comes to the neurotoxicity of the drugs, this stuff has been studied extensively, and there are simply no studies showing harm from the administration of the spinal or epidural morphine. This is one of the studies. There is a huge number of studies that's available, but when it comes to the toxicity of the morphine, either in the animals or in the humans, there are just no studies reporting that. So what dosage should be used when it comes to the spinal morphine? At the Stanford University, they use 0.1 milligram of morphine. In New York, here the dose is 0.15. It's up to you to decide whether you want to use what's used on the West Coast or on the East Coast of the United States, 0.1 or 0.15 of morphine. I also have to show you the biggest OBGYN, obstetric hospital in Serbia. The hospital is called Narodni Front, and if anyone didn't understand, that's a People's Front, and the very World War II name, and the hospital is sort of, the building is from that type of, from that period. And they use 0.2 milligrams of morphine. In United States, we think that this dose is a little bit too big. In United States, we have basically three main manufacturers of morphine. There is no differences between them. And when we look, me and my colleague Oleg Turkot, when we looked online about the Ukraine, we actually found that in Ukraine, in Kharkiv, you have the company that manufactures this morphine. And as much as I could read the Cyrillic, it looks like that the chemical content of the morphine that's manufactured in Kharkiv is pretty similar to the whatever we have available in the United States and what's available in the rest of the Europe. So I see no problem that this morphine to be used for your patients. How should we monitor these patients? Well, this is the recommendation from the Society for OB Anesthesia and Perinatology, and what they have said is that depending on how much morphine you give, if you give up to 50 micrograms, there is no need for monitoring. For the respiratory depression. If you give 50 to 150 micrograms, that's here in the middle, patients should be monitored for 12 hours, every 3 hours. And if we give more than 150 micrograms of morphine, that patient should be monitored for the 24 hours. First 12 hours we go every hour, and then second 12 hours we go every 2 hours. This is all on the Society for OB Anesthesia and Perinatology website, and this is used in majority of the US hospitals. So how can we conclude this lecture? First, Intrathecal morphine is the gold standard for the analgesia after cesarean delivery. In the United States, I would say 99% of patients that goes and that get spinal anesthesia for cesarean delivery, they get the spinal morphine. Also, intrathecal morphine has been used for the analgesia after a wide variety of abdominal and orthopedic surgeries. Am I suggesting that you should stop using thoracic epidurals, erector spinae plane block, quadratus lumborum block, TAP blocks? No, absolutely not. The places that do erector spinae plane block should do the erector spinae plane block or erector spinae plane block with the catheters or all of these fancy new regional blocks. However, when it comes to this block, at least in the country where I was born, you may have 5% of anesthesiologists capable of doing it. But and it's not easy to learn new blocks and have the ultrasound machine. Instead of that, spinal morphine will cover a lot of pain, and many patients will benefit from it. Also, morphine chloride is available and already in use in several Ukrainian hospitals, and I don't see the problem or the objection why it shouldn't be used in majority of the hospitals in Ukraine. And if anyone is concerned about the toxicity, no one has reported the neurological complications that were result of the spinal and epidural morphine. I will be glad to answer any questions that you might have, dear colleagues, and thank you so much for listening to the lecture. Bye.